All right, well, welcome everyone. My name's Darren. I'm the Director of Lifestyle Medicine and Health Research Centre here at Avondale University College. And tonight we actually have two special guests. I've been really looking forward to this, and I really want to thank you, our guests, for joining us. I'll be introducing them in just a moment. But this particular Zoom session, which is open to all, is actually part of a unit called Processes in Lifestyle Medicine. And what we've been looking at is part of the postgraduate degree here at Avondale. And what we've been focusing on is how lifestyle medicine can be administered. And last week we heard from the legendary Professor Gary Egger about how it can be administered in shared medical formats, and he had some other ideas for us as well. But tonight, what we're going to be focusing on is what I think is really, and I use the word gutsy, I suppose. It's not very scientific, is it? Although gut is a medical journal, so maybe gutsy is okay. But look, I think that what we're going to hear from tonight is two people which I have great admiration for. I think that they're real innovators in this space, and what they're really doing is pioneering what I would like to see a model that really flourishes here and in Australia and beyond. And that is really setting up lifestyle medicine dedicated practices and clinics. And so we have two guests. We have Dr. Riess, and we're hearing from her in just a moment, and Dr. Andrew Pennington. Michelle's based on the Central Coast. Andrew's in Sydney, in Hornsby, on the north side of Sydney. And so this is going to be fairly informal tonight. It's going to be a bit of a Q&A. We'll hear from each of them respectively, and I'll be asking a few questions. And then there'll be the opportunity for you guys to ask any questions that you might like to as well. Because as I said, I really think that what they're doing, it's very inspiring. I think it's very innovative, and look, I actually run a lean startup myself, and I understand how tricky it can be to get a successful model that works. And so these guys are really paving new way, and they're both very, very passionate about lifestyle medicine and operating at the forefront of that. So it's a real delight to have them with us. I might introduce them just real quickly so that you get to see them. But first of all, Michelle, really nice to have you here. Do you want to tell us just a little bit about your background and what you're currently doing, just in a few minutes, and then we'll talk more about your centre.
Yeah, absolutely. Yeah, thanks, Darren. As I said, thanks for inviting me. It's been a pleasure to have known you for all of these years, because I think your passion is amazing. So, so my background, I originally South African trained and then worked in Canada for about 10 years, mostly hospital based, and then moved to Australia in 2008. And have been a GP, started in general practice weight management clinics, and then through that met Gary Egger and was introduced to lifestyle medicine and just realized this is what I really enjoy. It makes a lot of sense to me. It's the way I like to approach patients in general, and having come from a hospital setting where I did a lot of emergency and hospitalist work, and that, you see the end result of people with their chronic disease. You see your heart attacks and your strokes and your renal failures and all of those. And I think it's really amazing to be able to now make a difference at the start of all of that. So patients, looking, as Gary likes to say, looking at the cause of the cause of the cause. And in my work with lifestyle medicine over the last few years, it's just been very, very fulfilling to work with patients, reverse their chronic disease, improve their quality of living, just assist them with that whole biopsychosocial approach. And I think it actually in the end makes a lot more difference to that patient than just seeing those patients present to ED and you see them for a little while and they're gone. Yeah. And they reoccur. So yeah, it's been extremely fulfilling. So
awesome. So I'm going to ask you some specific questions in just a moment about Lifestyle Medicine Centre. Before we do that, we'll flip to Dr. Andrew Pennington. Andrew, really nice to have you with us here too. Andrew, once again, a great advocate of lifestyle medicine, and is now, well, actually, Andrew, maybe if you can just do a brief introduction of yourself.
Sure, lovely to see you all, guys. Lovely to see you, Michelle. And thanks, Darren, for the invitation. Like Michelle, obviously, I'm very interested in lifestyle medicine. I guess I've always been interested in healthy living, it was part of my upbringing and background, plant-based diets, their role, exercise, stress relief, all of those things. But probably it became most apparent to me, I think, of the power of it, probably around when CHIP was being relaunched around 2012 and 2013, for those of you who know the CHIP program. And I was involved in CHIP training, and I did the program, and I actually really I was really blown away, I must say, by some of the testimonials of some of the people who had quite significant chronic illness. I remember one of the ladies who had end-stage renal disease and had peripheral neuropathy and a lot of problems. And generally in medicine, we don't see any reversal to that. It's just one more medication, essentially, okay, next stop, renal transplant. And this particular lady's story of the power of lifestyle medicine saw that she actually, not completely, but virtually completely reversed her renal failure, and her peripheral neuropathy went away, and a number of things went away. And I went, wow, I want a part of this. This is crazy. Like, we should be doing this in medicine. So that really spurred me on. And then I was at that time, I was working as a rural general practitioner obstetrician in Victoria, and really loving it. But then I got an invitation to join a clinic that was being set up in Sydney called Sanctuary Medical Practice in Pyrmont, that was, or at least set up by Sanitarium, who were interested in doing a health clinic, and they asked me to be a part of it. And I said, yes, I'd like to do that. So I relocated back to Sydney and was a part of that. It wasn't, after a while, I realised it wasn't actually like, it was trying to do lifestyle medicine, but it probably wasn't as successful as it could be. And there was a number of reasons for that, which I won't go into today. But eventually, unfortunately, it closed. So I had an opportunity to either join a new practice or start my own. And I'd already had a passion for lifestyle medicine. I already knew that I didn't want to go back to doing 10-minute sort of consultation medicine with patients, because I didn't feel that you could make as much impact on short-based medicine. So I thought, well, actually, no, I can choose to practice medicine how I want to practice medicine. And I'm actually going to offer a different modality and a different style, and that's longer consults with lifestyle-based therapies. But at the same time, I was also learning about the power of nutrition and vitamins and minerals and various other complementary medicine strategies. So interesting, I can talk more about that later if you like, but what that, I guess, offered was, and I'm sure Michelle can probably speak to this as well, it's difficult to attract people to your clinic to do lifestyle medicine per se. Like, it's not as sexy as it should be, perhaps. And so patients kind of maybe struggle a bit with the value proposition. But if you have some complementary therapies to offer them, they are interested in that. And there's a lot of people who are interested in that, for rightly or wrongly. And I don't want to go into that necessarily, but that was where I've also explored. And so what I try to do with my practice is do lifestyle medicine histories and taking care of that. And often that's all you need to do. But occasionally there's things I need to actually do that complement that, or enhance that, or get them ready to be able to do their lifestyle therapies better. And that's basically what I do in my current practice called Sanctuary Lifestyle Clinic in Hornsby. So yeah, lots of things. But
yeah, that's a great introduction. We're going to come back to Michelle. So, hey, what I want to say tonight is that really, Andrew, you mentioned that your original appointment really in the lifestyle medicine space was at Sanctuary Health Clinic, which was owned and operated by Sanitarium Health Food, or Sanitarium Health and Wellbeing Company, and they'd set up a lifestyle medicine clinic in Pyrmont, and it wasn't successful, by and not putting criticism in, or laying blame on anyone whatsoever. But I think just to brief everyone here, I actually really, and you mentioned, I won't go into the details of, what may have contributed to not being successful, or what may have been able to have done to make it more successful. Actually, I think there is some really valuable learnings that come through that. And why I'm really fascinated to talk with both of you tonight, and I think that, with all respect, this will be probably, heard by others in the lifestyle medicine community, many of which might be thinking to themselves, hey, you know what? I completely resonate with what Michelle and Andrew are talking about tonight. And and I'm not quite sure if I'd be courageous enough to do what they're doing, but hey, maybe I'm entertaining the idea. What's some pitfalls that I should stay away from, or what's some things that I should consider that would actually help set this thing up for success? So I would love if, and obviously, I don't ask you guys to share anything you're not comfortable sharing, but just sort of keep that mindset on that there are people here that maybe are looking to you and would love to, receive some learnings from you. So anything that you're comfortable to share that you think might be helpful in that regard, we'd greatly appreciate it. So to come back to Michelle, so tell us about tell us about the Lifestyle Medicine Centre now. How did it actually come to be? Got a little bit of a backstory. You mentioned how it's really interesting when people come to lifestyle medicine conferences. So it's the same speak. You often hear people go, it made sense to me. And I think Michelle used those words. It just made sense, and then all of a sudden they say, I found my home, I found my tribe. And it's very much that experience for many. How did you go from that point to where you are now? Because, tell us about the Lifestyle Medicine Centre and how it came to be. I think you're on, there we go. You just need to unmute yourself. Sorry.
There we go. Okay. I'll start again there. So just so to understand the other attendees on the meeting tonight, am I talking to GPs or is it a mix of GPs and Allied Health?
Mixed bag in here.
Mixed bag. Okay. So yeah, I think the amazing thing for me was then signing up and doing the international board certification exam, because just even going through that, as I was learning those things, I could already start applying that in my general practice. So that was very, very helpful for me. I think it's an amazing exam to do, and it gives you a really nice overview. At that stage, I did the first international exam, and that was based on the LMCCs, the Lifestyle Medicine Core Competencies. I think it's changed now to the foundations, and I'm not sure exactly if there's any difference, but honestly, I think the whole overview that the LMCC gave me and the board exam was incredible. So where I was at the time in general practice, I had set up, I was within a fairly large general practice, and we had set up our chronic disease clinics, and one of them was a weight loss clinic. And having set that up and seeing a lot of those patients, we started at the traditional, okay, you need diet and you need exercise. But having seen those patients, I just came to realize that there's a lot more than just diet and exercise. And then having done the board exam, there were just so many check boxes in that in terms of, the whole person approach. So, which I use every single day now in my practice. And I do, quite a lot of talks and have been invited to talk internationally on, the whole biopsychosocial approach to patients. And the world is sort of moving in that patient-centered care, which I think lifestyle medicine is 100% the best specialty if you want out there to do patient-centered care. So with the Lifestyle Medicine Centre, I then set that up. It took me a little while understanding how do I incorporate lifestyle medicine within my general practice. For me, what made sense is I started with shared medical appointments. And then I was confused. So how do I combine shared medical appointments with, individual consultations? And then I also realized, but I want a team, I really want a team around me, because you see patients and you realize, well, I'm a bit limited as a GP and under the current Medicare billing to, really address some of those more complex issues that come out. So I tend to see patients in the beginning. I assess them biopsychosocially. I identify barriers in all of those three spheres, and then talk to the patient about how we're going to go through over the next few weeks and months addressing those different parts of it. And then realize that for those patients who needed extra dietary advice or exercise or psychology or life coaching, I could do quite a lot of that and do that as an overview, but then they did need a bit more intensive work with that. So I actually brought other allied health on board with me and decided to open the Lifestyle Medicine Centre. That now, Darren, you may not know, but as of yesterday, I opened a new practice. So what I've done is I took my my general practice and my lifestyle medicine center, and I've now combined it into one location because I was working out of the two. So the lifestyle medicine center was set up as a referral center. So we'd receive referrals from GPs and allied health and specialists for weight loss and lifestyle modification in that whole chronic disease space. It was difficult for me to work out of the two, so now I've gone and combined it into one, so I can be in one place, and we're trying to set a new benchmark in primary care with that whole patient-centered approach, with on-site dietitians, with 3 dietitians, a life coach, exercise specialist who actually is doing exercises on site, not just giving patients, stretching and exercises to go do at home. We have the first clinical pharmacist on site. So in that chronic disease space, he'll sit and do medication reviews. He's part of the, so Medicare actually gives you incentive payments similar to a chronic disease nurse to have an on-site clinical pharmacist to assist with your chronic disease care plans and everything. So we only opened that yesterday, and I'm quite happy to talk about things. I'm not protective or possessive about anything, because I think the more people that can actually do and start applying this different model of care, especially for our chronic disease pandemics, the better for everybody. So
tell me, Shah, so originally you had, like, you're in the one for, like, you had the Mingara Health, I think it was, wasn't it, when I was there? And that was quite a standard general practice.
General practice, yeah.
And then you had a floor above, which was dedicated to the Lifestyle Medicine Centre.
Yes.
So how did you go? Because you mentioned that you were getting referrals from specialists and that. How did that work for you? Did you have enough, other health professionals that were willing to refer on that saw the merit of it?
Yeah. So I must say there's a bit of resistance in some GPs. There were a few GPs that were very keen to refer their patients, and they're quite open to it. And then you had your other GPs that were a little bit, I suppose, scared of losing their patients, because once patients come over and they realize that you are approaching them with they're not there just as, here's your prescription, off you go. We're actually looking after the whole of you. And a lot of patients want that. I suppose sometimes they may want to change GPs if they feel that they're finding a GP that is a little bit more interested in them. So there were some GPs that were a little bit precious over that, but others were actually, and I actually made it, because it was a referral center, I was very clear that if patients came in with other GPs, that I communicated with those GPs. I sent them notices to say, if the patient allowed me to and wanted me to say that, your patient has presented, I'm not going to bill any of your chronic disease item numbers. I'll keep you up to date. You'll be CC'd in on all the pathology. I'm not going to change any medications. And I'd often make phone calls to GPs and discuss that, and they appreciated that. Some patients came in and didn't want me to communicate with their GP, and obviously, that's their right, and I had to respect that. So that's where GPs are concerned. Allied Health, incredibly supportive. They probably the most supportive, and then there were a range of specialists as well. So I had cardiologists, obstetricians, orthopedics particularly. So, before they do knee replacements or hip replacements, they'll often tell patients to lose weight first, and then they'd refer them to me. And then I'd work through that until they were at a point where they could then, go back to the specialist and have their knees done. The cardiologist would refer, because obviously, they'd see patients, and a lot of they would sit in the lifestyle and they have no idea what to do, and their GPs are not necessarily comfortable or knowledgeable or interested in talking weight loss or lifestyle modifications. So they'd refer them to me. And as I say, Allied Health were incredibly supportive. So I don't do any integrative medicine or complementary medicine like Andrew. I just, I do traditional medicine, but just then with lifestyle as addressing the cause of chronic disease instead of just band-aiding it or just managing it. Yes.
So tell me, I'm amazed that you're actually with us tonight, given that you've just opened a new centre, by the way, so really appreciate that.
That's why I was late, sorry, because I literally got it.
I'm amazed you're here at all. So how many people, how many team members do you have in your new centre then?
The new centre now, as it's called Life Medical Centre now. So, maintaining that life and lifestyle side of things. Yeah. And at the moment, somebody actually asked me yesterday, and I had to count. So we've got 17 people as part of our centre.
Wow. Okay, we're going to come back to you in just a minute. Andrew, tell us then, so this is quite a large centre. You were part of Sanctuary, which actually had quite a number of health professionals associated with it too, didn't you? And then obviously I'd say that probably, I actually haven't caught up and had a good chat about how it's going real recently, but I would imagine it comparatively a smaller enterprise. Can you tell us about that?
Sure, it's much smaller what I do. And look, the reason for this has simply been a business model scenario. I think we just lost Michelle, did it? Yeah. So Sanctuary in Piedmont was planning to be a lot bigger and have a lot more, facilities and interdisciplinary care, which is great in theory. But unfortunately, it perhaps just didn't work out the business model very well, and it ended up, costing more than it should. And that's a very sort of small synopsis, and there's many other reasons why. But I think there are some learnings there. I think if you do start in lifestyle medicine, you need to be prepared to start small. I wouldn't be starting too large, and you really need to not rely on that as your sole source of income initially until you get a reputation that people will be actually wanting to come and see you. So I've been fortunate, and I think in reality, I get a number of lifestyle medicine patients who come to see me because they want the holistic lifestyle medicine. So I have quite a few of those, but I probably get more people who come through the door for integrative medicine. And that's what has paid the bills for me, essentially. And I would probably rather do more lifestyle medicine, but it's, as I said to you, it's not as sexy. Integrative medicine is a little more, I don't know, in demand, for whatever better term. So I use both of these things, and sometimes I've got to make a judgment call where I start with the patient. So, for example, even though there may be some excellent strategies of lifestyle medicine in someone who's depressed, if I can't help them correct that chemical imbalance in their brain first and tell them, look, you need to do more exercise and sleep better and eat better, they might go, well, doc, I can't do that, or I'm struggling to do that. You've got to actually offer them something to help them before you can get to that point. Now, that's not all patients, but it's just an example. Some patients you've got to help in another way before you can get them to really correct their lifestyle. So I'm very, I guess, adaptable is what I would say there. But so if you're wanting to talk about learnings, one is start small, don't rely on it as your sole source of income, and develop a reputation. And I realise that there are people here in this room who are not GPs. There's a number of you who are allied health practitioners. You will find it easier to do lifestyle medicine because, for example, if you're a dietitian or exercise physiologist, it's really, you are practicing a field of lifestyle medicine already. So you are already going to be having that impact. But I would say to you, unless you are aligned with the referral practitioners or the people you work with, you probably are not getting as satisfied with what you do as you could. And you can hear that from Michelle, what she was just sharing about her practice. She's obviously got on board a number of people who really appreciate her philosophy, and they feel, hey, I'm part of a team that's of the greater good. So the best example I can use of this is my nurses. So I have 2 nurses in my practice, and they love being there because they're doing something different from the standard, medical practice nursing. And it's a little bit easier for them. They don't work quite as hard. So they probably enjoy that aspect. And they get the opportunity to do some health coaching with patients and to, do some chronic disease management plans, etc. So it's very good, I guess, for them. And I encourage them and try to encourage them to learn. And one of my nurses who's since left me had gone on and done the board certification in lifestyle medicine, which I would highly recommend everyone consider doing. As Michelle has said, it's a fabulous way to understand lifestyle medicine holistically. My other nurses are probably going to work towards doing that. So the model evolves a bit. I've actually, what happened to me I originally was located in Waitara, and unfortunately, I also overcapitalized as well. I thought that I would get more practitioners in, more things, more people in, and more patients. That didn't happen. And I guess I'm in an area where there's no shortage of GPs. So it wasn't like I was addressing an area of health need specifically, even though what I was doing is different. But so I've actually downsized. I've gone to a smaller practice now, a smaller location, and I'm focusing on just the things that I do well. And then with time, I may be able to add by either expanding the practice or taking on, renting another room somewhere or another area of the building I'm in where there is a number of different facilities. That's a possibility in the future. And ideally, I'd like to do what, expand the concept that I have into other places around Australia. But I think this is something we can talk a little bit more about, but the financial side of things is really heavily weighs on how you can do this. And you have to think through that very carefully, because it just doesn't work if you can't make a business work. It's as simple as that. So you really do have to be savvy about that. And I can give you some thoughts on that. So if you are thinking of starting, for example, in lifestyle medicine as a GP, and you want to go out to do that, you really have to understand your patient population and where you're going to set up. And that really dictates the billing structure that you're going to charge, etc. So in my area, where I'm in an area of Sydney where there's a lot of people who can afford to seek medical health, I have a full private fee. I do bulk bill children under 5 for illness consults, but that's because I still want to do general practice as well as lifestyle medicine. But the majority of my patients are paying a private fee, and they can afford to do so. I do have discounts for healthcare cards and pensioners, but yeah. So those are things you have to consider. But if you went to set out, let's say, somewhere in Western Sydney where there was a poorer demographic, for example, you may find that you have to adjust very carefully about how you bill. And one of the tenets I find is that it's very difficult to do lifestyle medicine quickly. Unless you do shared medical appointments, which is certainly a good way to do it quickly, but there's some issues over how you bill that, etc. So there are some tricky things to navigate. But one of the things, as we probably know, is it's about the rapport you develop with your professional. So I don't know if you guys have got your own GPs, but if you don't get a good rapport with your GP and you don't trust them, then you're not going to be able to help them shift change. And so a lot of what I do is about developing that rapport, trying to, mold myself into what the expectation of that patient has, and trying to work out how I can help them and develop a trust. And once I can develop that trust, then it's much more likely that they're going to implement changes that I suggest to them, and also help them in motivating them to do so. Say a lot of things, but I'm probably going off track.
No, that's really good. And actually, I really appreciate you being, quite transparent and vulnerable in some ways to say, hey, I tried that and that didn't work. And I think that, one thing in business, they always talk about persisting or pivoting. If it's not working, we'll change direction. And I think, but it takes, when you've got momentum in one direction, it takes a lot of courage to change. So they're really good at doing
The trouble is, Darren, is that the medical system is set up as an illness system. It's not set up as a wellness system. So people come to their doctors when they're sick, not when they're well or wanting to enhance wellness in general, or not when they're wanting to prevent illness except for a vaccination. So, and that's the whole way the Medicare billing setting is set up. So it's not, you can, pivot it a little bit, and I'm sure Michelle can talk to that as well. So it's not that you can't use it, but it's much harder. And let's just use the example of if I wanted to spend an hour with a patient, let's just be honest with the figures. So the Medicare rebate for that is $110. And if I see 6 patients in an hour and it's $38 for that, then I'm going to get about $230 compared to $110. So you do the maths. You know, you can see if I'm purely bulk billing, that's the economics of it. It's very difficult to make it work, to have half a decent salary to pay your staff and pay all of your wages and your rent and everything else, to bulk bill in doing long consult medicine. So that's why you generally need to privately bill it, or you have to have some other income source or generation, or incredibly generous staff who you don't pay very well. And you just can't do that. So.
Okay, so really thank you for your thoughts there. So Michelle, coming to you, obviously, I mean, when I went and saw your facility at Mingara, that was a nice setup there, and it sounds like you've expanded upon that. So what's been some secrets of success there from your perspective?
Yeah, so I think what I've done now is I've just brought the two together. So I wouldn't really say, I suppose we have expanded, because I have brought on the pharmacist and, a couple of extra dietitians and that. I think, and I totally hear what Andrew says, and, he makes extremely valid points, which is really important for everybody to understand, that certainly the Medicare system allows for illness, and illness is based, and the Medicare system is based on, I'm the expert, you come in, you've got a few issues, I'm going to make a diagnosis, I'm going to give you a script, and off you go. And if you get better, great. And if you don't, we'll come back again. It's definitely not set up for spending time with a patient, figuring out, all the parts of them that make them tick and that's important in their lives. And it's also not set up for recurrent follow-ups, because if you're taking somebody through a lifestyle modification program, you see them regularly and they want to be seen regularly. So what we've done that's working for us is we have effective use of our chronic disease item numbers using our nurses, and now the pharmacist will be part of that. So just understanding how to, in our current Medicare structure, to use that well and efficiently. And then we do use shared medical appointments. So Andrew, don't know, it's nice to meet you, because I've heard about you. I think when we do the work that we do, people realize that there are different GPs around. That's not just your normal mainstream GP. I mean, I do mainstream medicine. As I said, I don't do integrative medicine, but, people sometimes don't know the difference between that, and they just realize there's a GP that cares a bit more and has a bit of a different approach, and your name gets out there. So I've heard of Andrew, and people talk very highly of him. I think, I use shared the SMAs as well, and we've structured that in a way that we've run many. And Andrew is right, there's a big question mark around the billings around that. I've had extensive discussions with Gary and John Stevens and all of those guys. They've repeatedly over the last 4 or 5 years gone to Medicare. And Medicare is not able to come back and say, no, you can't bill a group of patients, sitting together back to back. They haven't, and I've done that billing, and it hasn't been an issue for me yet. Hopefully it won't be, but I feel that if they come and they look at, the service we deliver and the documentation we provide around it, and that you see, say, 10 people in a group, and you bill them, for an hour and a half, 23s, what they gain in that time is the most successful part of what we've done at the Lifestyle Medicine Centre is our shared medical appointments. Because what the people gain from that, the community that they create within those groups. So we structured those groups so that they had an intensive phase where they really, you'll see week 1, week 2, they don't know each other. By week 4, they're chatting outside in the car park. And by week 8, they're exchanging telephone numbers. Mm-hmm. And then after the initial 8 weeks, they'd roll over into an ongoing SMA type drop. So the DIGMAs, the drop-in type programs. And then we had walking groups going and cooking courses and things like that. And then they connect there again. And even now, we closed the Lifestyle Medicine Centre for a while just so that we had the capacity to open the new centre. And those groups just get going, you know, those women are supporting each other. They're now swimming together. And, you know, you see Facebook posts. So we engage through Facebook and social media as well with everybody. You know, and they talk to each other and it's like, oh yeah, you know, I'd never swim, but here I am. I'm in the rain. I'm in the pool. I never started any swimming groups with anybody. They just went off and did that, you know, so it's pretty cool. I think in terms of fulfillment, other ways that we've run small pilot studies, you know, that we got funding for. We're aiming to apply for a lot more funding, because I think if we're starting to pioneer a new model of care, I really would love to see, and I'm engaged in a bunch of talks with people already, and, you know, just hoping somewhere the fish bites, that we will be able to pioneer a new model of care in the prevention, management even, and reversal of chronic disease. We need to put that evidence together. I think SMAs are an important way to go there, because it's so efficient in terms of, you know, in one-on-one consults, you say the same thing over and over and over and over again, say to 20 patients, or, you know, 10 or 12 patients. In an SMA, you say it once to all of them. It's great. Plus in our SMAs, our programs are, so we do programmed shared medical appointments. And part of those modules are also with, you know, obviously me and the nurse and that in attendance, are delivered by the allied health. So we'll have specific diet modules or exercise modules, you know, where the exercise guy actually takes them and does exercises with them in that module. We'll have psychology or life coaching in that as well. So, you know, that's input that those patients get that they would never otherwise get. And the providers really enjoy it. You know, they love it too. They really enjoy it. And then we work collaboratively as a team. So we actually case conference, have patients talk about, you know, moving towards patient outcomes. So it's, again, it's that patient-centered care. And then we're also launching, this is new for us, actually, it's not, we've run one trial guinea pig corporate SMA program in the lifestyle space, that we were approached by an owner of a business who was a patient and liked it so much. He wanted his staff to have access to it. So we had a condensed 5-week intensive program, and he actually allowed them an hour to an hour and a half of their Friday mornings of paid time to attend our program. And yeah, and that was really successful. So that was sort of a trial, and we'll be running out more probably in about 2 months from now. So that's all different streams, and part of our SMAs, and that's maybe where we're a point of difference too in terms of income, is although you obviously can't double dip, you know, you can't bill or charge something privately and then run your Medicare model as well. We have set up part of our SMAs that they get, they pay a private fee, and then they get other parts to that. So they, you know, we do DEXA body composition scans and a whole range of other things, which I'm happy to discuss, you know, which is what then their fee pays for, which is outside and over and above the Medicare items that we then as GPs charge.
Hey, Michelle, and Andrew alluded to the same thing. So both of you have hinted at this idea of, I mean, Andrew, you have your nurses, Michelle, you got your team, but you're even talking about the relationships that get formed amongst your patients. My question to both of you, perhaps start with Michelle, is how critical in setting up a centre like this, a clinic like this, having personnel that are on board, that are aligned with that philosophy and that mission of what you're about?
Yeah, I think it's crucial. You know, I think that's where a lot of other programs fall flat. You know, you see a lot of interdisciplinary programs, maybe in a hospital setting or somewhere, but if you don't have passionate people that are lifestyle medicine same minded, or that real person-centered, passionate way of caring, it's not easy to do. You have to have people that enjoy that way of working with patients. Yeah.
Andrew, you could comment on that?
I couldn't have said it better. I mean, it's it's an absolute must that you have people who are passionate about what you do. And this is true in any industry in life, isn't it? You know, I mean, if you go to any industry, you know, you go to the tiling shop and you want tiles and the guy's really passionate about it and he understands it all and he explains it, you're going to probably buy tiles from this guy. You know, it's the same with us. If we have an infectious passion about what we do, which I think probably you guys do have, and we have similar staff, you will enthuse your patients. It's no doubt about that. But it is absolutely vital.
We're going to run out of time, so we've got about 15 minutes left. Can I ask you a question? Obviously, you've shared a whole lot of gems already, and hopefully this has sparked some thoughts and some ideas for some other change makers out there. But if other than what you've already shared with us, are there any, you know, really good learnings for you that were, hey, you know, this, stay away from that, doing that, and hey, try this worked well for me? Any gems that you could share? Perhaps Andrew, would you like to kick it off? I know you've already itemised some of those things already.
I'm a little bit concerned that I'm talking too much to doctors, because I know there's a number of allied health people here. Can I ask, I mean, I want to try and address that from the allied health perspective, perhaps a little bit more. I have had a couple of people approach me wanting to work with me, and various of them have struggled to get the financial model working for them. So I guess that's why I said earlier, you can't necessarily early on rely on, if you're an allied health practitioner, rely on perhaps the work out of a centre who's just starting up in lifestyle medicine to be your sole source of income. You just can't do it. You'll end up bankrupt. So you really got to work in settings where you've got a stable income, and then, you know, do 1 day a week initially to start with, or whatever it might be. It you know, maybe with time, and I'm sure Michelle's very much on board with this, that as these type of centres get reputations, as the Life Centre, Sanctuary Lifestyle Clinic becomes more popular, has more patients, all of that stuff, that we will be able to sustain those kind of practitioners because of the increased thoroughfare of patients. That's a big one as a learning from my perspective. And yeah, look, I guess I'd just say, just learn as much as you can from those who are doing stuff in the area. Like, come and spend the day in our clinic. Come and do the board certification. You know, go and do a CHIP sort of course. Whatever it is that gets you enthused, be passionate about it, and you'll find somewhere to work in. And don't lose the passion.
Michelle?
I would say I get many questions around shared medical appointments, and I know I've now already spoken about that, but I think, you know, it can be daunting for people to go, okay, well, I know how to see patients one-on-one. How do I actually start shared medical appointments? And I'm happy to talk to anybody who's interested. You know, obviously it sounds like you had your talk last week by Gary about SMAs. I think it's an excellent model when it comes to chronic disease. So I think that would be a pearl that I'd say. Other pearls, I think, is be structured in your approach with patients, so that patients are clear about how you're going to take them through their lifestyle medical modification process with you. So I like to, you know, have an inquiry visit with patients. They'll come in because they know I'm a lifestyle doctor. So they'll come and I'll explain to them, okay, so my approach is biopsychosocial, meaning biologically, we're going to do some bloods on you. We're going to see where you're at. I need your history and all that. Our nurses do that to start with, so that by the time I see them, I've got that information. You know, patients come and see me, and then I'll diagnose, you know, their cardiac disease or their insulin resistance or whatever it is, because they didn't even know necessarily that they had that by the time they came to us. So you know, so we look at things medically, and I usually start with that and say, okay, we're going to exclude, if somebody comes with fatigue, overweight, you know, just not living the best life that they can, I'll sort of say, right, okay, we need to do the medical side of things first, check their iron and thyroid and, you know, all of those other things, identify if there are any barriers there. But then at the same time, I explain to them, but we're also going to look at you know, any psychological barriers or any social issues. And I suppose with experience now, I tend to nut into those barriers really quickly. You know, if somebody has had, you know, maybe they're in a domestic violence relationship, or they've, you know, just got real low self-worth problems because of whatever it may be. Maybe they had trauma somewhere. You know, I tend to hone in on those quickly, because often if a lot of those psychological things pose a barrier to ongoing, maybe they emotionally eat. You know, I do talk a lot about your reward centers and some of those addictive tendencies around your dopamine and things like that. And, you know, patients, if they understand that, it really helps them shift from that external source of reward to an internal driver of reward, which really, you know, is quite beneficial in them going, oh, wow, okay, which helps them, because you can tell patients, look, yeah, you know, here's your diet, you got to eat this way. Although I don't like talking about diet, I just talk about a lifestyle. But, you know, this is how we're going to change things. I give them food diaries. That's something that's very helpful if you use a food diary across a week. And think about, I'll sometimes send patients home, and even on the inquiry visit, I'll give them a food diary. I say, okay, great, come back. If you're interested in what I've explained to you about how I do things, and invariably people always are, because they're just so thrilled that you're actually going to look after the whole of them. So I'll give them a food diary and say, okay, come back next week, just chart your food and your exercise for the week. And so often you get patients, and it's so good to then elicit those patients who have their barriers maybe is that they actually have no idea how to cook. I've had patients who don't even know how to cook rice, you know, or you look at it across the week and you ask them, so what's the main color that you see on this food diary? And then it's chips, bread, lots of milk, you know, takeaway foods, burgers, sandwiches. And then when you say to them, look, let's try and just change color. Let's just try and make it more colorful for the week. You know, there's a penny that drops because it's so practical. So look at your day and see if you can get some greens and some yellows and some reds and some purples in there. And automatically there you're talking about your fresh fruit and vegetables that they've got to bring in. You know, so, anyway, I mean, there's just so many things that I can talk about, but, you know, so I think coming back, so structure your approach in your own mind, go clear, okay, biopsychosocial, let's find out what's good, let's find out what the barriers are, and then you explain that to the patient. This is how we're going to take you through, and make sure your documentation suits that and fits that. Have paperwork that you can use. So use your lifestyle medicine prescriptions. You know, you learn that in the international, in the IBLM exam. I use that on a regular basis. Use diagrams. So I've got something where I use a puzzle, you know, and I talk about this patient. This is the whole of you. We're going to talk about the different puzzle pieces. You know, you want this life, this quality of life later. So if you have a barrier or an issue with your food or with your exercise or with your relationships or with sleep or with an addiction or whatever it is, you know, we unpack those puzzle pieces, we'll address each one of them, and then we'll put them together. So just find ways for yourself to have structure for you and for your patient.
And you know what I really love, you mentioned there, Michelle, and you've used the term quite often, is this sort of whole of health approach, recognizing that, you know, very holistic approach to, you know, the biophysical, social, as you refer to it. I know Andrew is very much aligned with that philosophy as well. And I've actually seen, I think over the years, we've seen an evolution in lifestyle medicine in that space. I remember in the early days at CIMA, we were very much nutrition, physical activity driven. And I think partly to the great work of, you know, quite a few different luminaries, but Gary Yeager being one of them, recognising that, you know, things like self-worth, as you identified, and some of these things can be major players when it comes to lifestyle change. We've only got a couple of minutes left, so and I want to be respectful of your time. But you know, in the wise words of Stephen Covey, one of his 7 habits of highly effective people, isn't it? I always think he talks about begin with the end in mind. So perhaps starting with you, Michelle, and then I'll ask Andrew, what does the end look like for you? I mean, do you have a firm picture of what you want this to look like? What will success look like for you?
Success for me or success for our community? And
I think success for the initiative you're driving, in terms of what do you see for this, for the centre?
For the centre, I think I would like to see us work out a model of care over the next few years that can show that it can be done to deliver lifestyle in primary care. Yes. And an interdisciplinary approach to lifestyle management, or actual general practice management, in a patient-centered way in primary care. I'd love to, create evidence or gather the data around that, so that, because there's nothing out there in terms of data about how do you apply lifestyle medicine or a patient-centered care approach in primary care that actually has a positive effect on health budget outcomes later, on holistic community wellness outcomes later, on patient satisfaction, so we measure, your PROMs, so your patient-reported outcome measures, of which we also obviously, you've got your biochemistry and your anthropometric measurements and things which you can measure. But, we also want to measure patient activation measures and patient experience measures. All of those things are the way that the world wants to go. They want to know what's the patient's experience, how are they activating. So I'd like to have the centre and our community as a whole really move towards being able to identify the need in that and what patients enjoy, and make it about the patients. Rather, I had this discussion with a pharmaceutical company yesterday. Make it about the patients, not about what doctors want and what, the academics think it should be. Make it about what the patients want. Anyway, you hear I get passionate, I can calm down a little bit.
Good, it's good. We love passion here. What about Andrew? Andrew, for you, what does the end goal look like?
Like Michelle, I want to see models of lifestyle medicine working well, and there are various models that it could be done in, and so that's very much the driving factor behind why I set up my practice. But I want to see it financially viable long term, and I want to see, at the moment, the end goal is to continue to touch people's lives on an individual basis. From my perspective as a practitioner, because I can really, yes, in shared medical, you can do more than one person at a time, but still, I haven't quite adopted that model yet, even though I've been aware of it for quite a while, and I would like to be doing shared medical models. But at the moment, it's an individual approach for me. And so I get absolutely passionate about seeing someone go from here to here and their health improve holistically in that biopsychosocial, spiritual, whatever model you're wanting to put on it. And that it's a holistic model that essentially allows that person to thrive. And I often say to my patients, my job is really to do myself out of the job with you. It's, I want to get you well enough that you don't need to see me very often. And, it's really shooting myself in the foot in that way. But fortunately, there's no shortage of patients.
It's true. Hey, we're going to tie it up there because I do want to be respectful of your time, but I want to say, deep gratitude to Michelle and Andrew for what you're doing. You guys really are leaders in lifestyle medicine, and I really want to affirm you in that and what you're doing. And I too have a great interest in, and I remember the first time coming down to Michelle's clinic there, the centre, I was just always fascinated because this is one way that lifestyle medicine wins. And I think that we need innovators, we need people who are courageous enough to step out and, take risks and chart new territory, because when that's done, others will follow. And so I just want to wish you all the best in what you're doing, and really applaud you for your efforts. And we wish you every success. We're cheering for you because this can really make a tremendous impact. And to me, the end goal, like you've articulated, Andrew, is to positively influence people's lives in very profound ways. And lifestyle medicine can do just that. And so the more that we can, make that mainstream and get governments to listen, and particularly the funding organisations to get on board, then the greater the impact we can have. So Hey, thank you so much for your time tonight, Andrew and Michelle. It's been really a real joy to hear from you. And thank you for being so open and transparent and sharing what you have. Yeah, thank you very much, and best of luck with it all. I'm just going to